Well, thanks for having me. Again, my name's Eric Miller. I'm actually currently a intern, first year psychiatry resident, um, actually at the University of Arizona right now. But the majority of this work was done as a final year medical student at the University of California, San Diego, working with Dr. Ramanathan's group and data they've collected from their ketamine clinic at the San Diego VA Medical Center. Next year, I'll be beginning the remainder of my residency training at Brown University in Providence, Rhode Island. So the general topic here is we were interested in understanding the way in which individual symptoms of depression change over the course of ketamine induction treatment and asking whether we may or may not be able to predict treatment response or non-response to ketamine using patients' baseline symptoms. And as mentioned, this work was recently published in Psychiatry Research. I will also mention that we did just immediately after that publish a core agendum with a few value changes that did not change any of the conclusions of the paper. So the overall approach, again, this is a secondary exploratory analysis of real-world data that was collected in this ketamine clinic at the San Diego VA. And questions, can we understand how individual symptoms change over repeated ketamine sessions? Can we predict non-response or response from baseline symptoms of depression? And if so, how do specific baseline symptoms relate to response or non-response? So the patients, we have 120 patients data here, all from one medical center specifically serving United States military veterans. Predominantly male, but there was 35 female veterans in this population with a broad range of ages. And all were referred for the treatment of treatment-resistant depression at this clinic. That being said, comorbidities were extremely common in this population, especially PTSD, with nearly 75% of these veterans having PTSD diagnoses as well. As far as the treatments, the majority did receive intranasal esketamine, though a non-insignificant minority received racemic ketamine. And this data that we're analyzing is over the induction sessions, which for the vast majority was 8 sessions over the course of a few weeks. A smaller number of patients received between 2 and 7 sessions. All patients received multiple sessions of induction therapy. So the first thing I'll talk about is how did we quantify individual symptom change trajectories over the course of ketamine treatment for these patients. So first, just looking at average scores across the patients before we go into individual patients. On the left, I'm showing the average PHQ-9 sum scores averaged across patients for each of the 8 ketamine induction sessions. You can see that this does improve over treatment. And then I'm showing the average across patients for each individual PHQ-9 item score. And we did test that each one of these individual symptoms were also improving over the course of ketamine induction for these patients. But this is average across patients. Really, we were more interested in individual patients within subjects. So the next thing I did is I looked at individual items trajectories for individual patients. On the left, you're seeing an example item trajectory for one patient and that item score across time throughout the ketamine induction, each dot being one recording of that item. I wanted to have a way of capturing the rate at which this item was changing for a given patient, and I tried 2 models, a linear model and an exponential model. The exponential model, inspired by some prior work cited in the below, suggesting that exponential trajectories may be useful for other treatments for depression. And I then evaluated which one of these to use using AIC and BIC. These are 2 methods for balancing the balance between the likelihood, the log likelihood fit of these models versus the number of free parameters those models are utilizing. And in both cases for AIC and BIC, the linear model was better for the majority of patients, meaning that because it had fewer free parameters than the exponential, yet still fit quite well, it was judged to be a better model and a more parsimonious model. So, therefore, for the remainder of this analysis, I use slopes of the linear fits to model individual item changes for patients. I then looked at, for each item, the average slope across the patients. So here I'm showing for each of the 9 items, the average across patients of the linear slopes for those items. And you can see that all of the slopes are negative, meaning that all items did change did improve over the course of treatment. Here, a negative slope is an improvement. But we did see that there was some difference in the rate of improvement. In this case, the symptom of depressed mood did change at a significantly faster rate than the symptom of what I'm calling tiredness here, which is the low energy symptom of the PHQ-9. And that is controlled for multiple comparisons. But we didn't really just want to think about individual symptoms one at a time. Really wanted to think about how are all the symptoms changing together? What are the distinct patterns of change of symptoms? And so the way I did this is principal components analysis in the space of item slopes. So you can imagine that each patient has 9 slopes characterizing the 9 rates of change for each individual symptom. Therefore, each patient could be thought of as a point in 9-dimensional space of slopes. I computed principal components analysis on that space and then looked to see how many principal components are significant in terms of describing the maximal variance of patients in that space, and did find that the first 2 principal components were both significant via a parallel analysis method, and they capture together between 60 and 70% of the variance across patients in this space of symptom trajectories. So the next question was, can we examine these first 2 principal components and ask, what are they telling us? What are these components telling us about how symptoms are changing for patients? So the first principal component, you can notice here, this is the coefficients, the coefficients of each item for the first principal component. And you can see that they all have the same sign. In this case, they're all positive sign coefficients, indicating the first piece represents a change as a kind of weighted sum score. The second principal component, in contrast, had some items with a positive coefficient and some items with a negative coefficient, indicating differential variability across clusters of symptoms. And interestingly, it wouldn't have to have been this way, but interestingly, the symptoms did cluster into what we're labeling as an affective cluster, symptoms such as SI, feeling like a failure, depressed mood, and anhedonia, and more of a somatic cluster of changes in motor activity, concentration, energy, and appetite. So using these first 2 principal components, we then projected each patient into that space of the first 2 PCs. Here, each dot is a single patient, and this is their projection into those 2 PCs. And then I'm coloring them green and red according to the sign of the first PC. Which side of the 0 point on the first PC are they landing? And I'm thinking of this, and I'll show you why, as a data-driven measurement of response and non-response, where those with a negative sign of the first PC are responders, and those with a non-negative sign are non-responders. Because of the way you have to normalize by the mean of the data to do PCA, another way of thinking about this is the green ones are ones that are having more change on the first principal component than average, and the red ones less change than average. So this was our measure of response. And to kind of confirm that this really is a useful or a valid measure of response, we went ahead and went back to the PHQ-9 sum scores and split the patients according to whether they're negative PC1, the green, or a non-negative PC1, the red, and then used just the standard old PHQ-9 sum scores and showed that, yes, in fact, the ones we're calling responders improved across the induction sessions, and the ones we're labeling non-responders did not improve over the course of these sessions. So this was a confirmation that this is a useful way of a data-driven measure of response. The next thing we asked is, do any basic demographic features correlate with response here? And I looked at a few simple ones and found that actually we were not able to detect any significant differences in the first principal component based on age, gender, esketamine versus ketamine, or PTSD diagnosis among these patients. We were not able to use these basic demographic features to differentiate patients along this dimension. So we then asked, could we use something else? Still something quite simple, baseline PHQ-9 symptoms. Could we predict response or non-response using a patient's symptoms on the PHQ-9 before they received any ketamine? And the way we did this is a simple logistic regression. Took each patient's baseline item scores, or subsets of those scores. I actually tried all of them, and I also tried different subsets of those, and ran logistic regression to see if we can categorize patients effectively into responders and non-responders, and then tested this using a cross-validation methodology. And I found that actually we are able to predict response and non-response better than chance using baseline symptoms. However, it's only a little bit better than chance. It's only about 60% accuracy among the best of these models. So better than chance, but perhaps not the most clinically useful of findings here. But nonetheless interesting, and I asked what could be driving this ability to predict. And one of the things that I found interestingly is that if you look at the average baseline response across patients on each of the 9 items, you see that responders had on average higher scores on all of the 9 PHQ-9 items than non-responders. In other words, patients with more severe baseline depression were more likely to respond here. And this is simple logistic regression models, and I'll return to this later. However, because 60% is not super useful, likely, from a clinical standpoint, I asked is there a way that I could optimize for predictive value, even if that might mean that we aren't able to capture as many of the patients. And the way I did this is I experimented with a method called threshold tuning. And the way it works is the following. In logistic regression, what the regression model outputs is a probability of response, a probability measure. And usually in a standard logistic regression, a decision threshold of 50% is used, such that if the model says there's a 51% chance of response, you would classify that patient as a responder. However, there's no reason you have to use a 50% decision threshold. You can actually try different decision thresholds. In this case, I'm showing a red one here, which it could be conceptualized as tuning for non-response, and a green one as tuning for response. And the reason why this is you can imagine if you move the threshold over toward the 30% mark, you would have this section I'm coloring here correctly predicted as a non-response, that none of the green is over there. So your negative predictive value would be higher. Of course, this comes at the expense of some increase in false positives. In other words, incorrectly predicted response. So it's a trade-off. We then did a similar method where we looked at baseline symptoms of depression or subsets thereof, but then also applied a threshold tuning where we tried many different thresholds and then cross-validated those and looked at the trade-off between predictive value, for example, negative predictive value or positive predictive value, the trade-off between that and the coverage of the relevant cases, sensitivity or specificity. And that's what I'm showing on this plot here. This is a bit of a complicated plot, so I'll walk through it. On the x-axis is the positive predictive value or negative predictive value for the green and red curves respectively. And the y-axis is the coverage of the relevant cases, sensitivity or specificity respectively. And again, as I mentioned, as you move the decision threshold, for example, to the red line here, what that does is it increases the negative predictive value. So it would push you toward the right on this plot. But the trade-off is it would also lower your coverage of the relevant cases, in this case, specificity. So that's the trade-off we have here. We argued that this is a trade-off that may be more clinically useful because even if you can't predict every single patient, if you can say that the patients you do predict to be a non-responder, you're fairly confident that they actually will not be a non-responder, that's clinically actionable or more likely to be clinically actionable data than to just say 60%. So the thing we then asked is, are there any models that have a good balance of negative predictive value and coverage of the relevant cases? And here in the top right corner of this plot, I'm highlighting what I'm calling quote unquote high performance models. These are models that we set out to say would have a quite high predictive value, greater than 90% predictive value, while at the same time managing to capture at least a bare minimum of 10% of the relevant cases. Within that high performance, I then looked for ones that have the best balance of predictive value and specificity. And this one that I'm pointing to here would, if you just say which one has the best average of predictive value and specificity, this one here would have 91% negative predictive value and 20% specificity. I will note for this is the value that was changed slightly lower than in the original public conclusions, interpretations, or findings from this result. So this is how we captured these high performance models. We have found no such high performance models for predicting response, however. So then we therefore focused on these models for predicting non-response with very, very high negative predictive value while maintaining at least a minimum specificity. So now that we said that we can do this, at least to some degree of effectiveness, the more interesting question was, what was the relationship between baseline symptoms and response? Could we understand something about what it was about patients that would help us to understand if they would respond or not? And so I'll return first to something I talked about previously, which was that overall higher scores on average on all of the symptoms predicted response for these patients. This is the same plot as before. And looking at this a little closer, one might think, could this just be regression to the mean? And I don't think regression to the mean fully explains these data, even though it is true that the responders started higher. It's also the case that they did not converge to a common mean value at all. The responders actually improved much more by the end of treatment, though regression to the mean may be playing some role. However, I wanted to know not just on average, but relatively speaking, what balance of symptoms helped us to predict response and non-response. And this is where it gets a little bit more subtle, but also more interesting. Relatively speaking, some symptoms predicted response, but also some predicted non-response. And I'll explain this carefully here, that there were some symptoms like depressed mood that relatively high depressed mood predicted response. You can also see that for anhedonia, energy, and appetite symptoms here. However, symptoms such as SI, self-harm, as well as changes in sleep, relatively high values on these predicted non-response. The best model that I highlighted before, the one that had that good balance of negative predictive value and specificity, it used actually only 3 symptoms: depressed mood, changes in appetite, and SI, or thoughts of self-harm, with those respective weights, positive for depressed mood and appetite, and a negative weight for SI. So how can we make sense of this, this relative change? One thing is important to note is this does not imply that high SI, high thoughts of self-harm, does not imply that that in isolation predicts non-response. In fact, we found that on average, responders had higher SI, and that is because higher SI correlated with high values on all 9 symptoms, actually. So it's not the case that you can just say a patient that has high SI is likely to not respond, not at all. What it does say is that this is a relative finding, and I'll give you an example to describe it. Imagine you have a patient A who has a PHQ-9 sum score of 18. And this comes from having scores of 2 on all 9 items. If you were to pass this patient through our model, you'll get a probability of response of, let's say, X. Now imagine you have another patient B who has the exact same PHQ-9 sum score of 18, but this patient, that 18, is coming from a 3 on the symptom of SI or self-harm thoughts, and only a 1 on the symptom of depressed mood. Our model would suggest that this patient would have a lower probability of response because the symptoms are weighted more toward SI with the same sum score. However, importantly, a patient that came in with a higher overall sum score, including a 3 on SI, this patient would have a higher probability of response, despite having the high SI, because all of this patient's symptoms were high, not an absolute finding with regard to the symptom of SI. So in conclusion, using linear models for individual symptom trajectories, we found that all 9 symptoms improved over the course of ketamine induction therapy, but the symptom of depressed mood improved relatively faster than the symptom of low energy. We found that you could explore patterns of symptom response using principal components analysis, finding that the first principal component, which captures over 50% of the variance in the data, is a measure of overall response, analogous to a weighted sum score. And the second principal component, interestingly, divided symptom change into affective versus somatic domains of symptom change, as you're seeing here. We also showed that we were able to predict response better than chance using patients' baseline symptoms alone, but only slightly better than chance at around 60% or so. However, using a threshold tuning method for optimizing the predictive value, we can find a better predictive value at the expense of a lower coverage of the relevant cases, which we argue may have more clinical utility for future models. And finally, using such models, we can explore the way in which baseline symptoms related to treatment response, finding that overall, worse baseline symptoms correlated with response on all 9 symptoms. But relatively speaking, certain symptoms such as SI and changes in sleep predicted non-response on a relative basis. There were several important limitations of this study. Most importantly, this is an exploratory secondary analysis. So many sources of potential bias, slicing and dicing in the data, selecting the findings that we find personally interesting, and overfitting of our models, all likely and may play a role in this. And therefore, our results are only hypothesis generating and do require replication with untouched data sets to know if they generalize. Also, a pro and con is that this is real-world clinical data. So we have no placebo control, no measures of expectancy were actually measured before these trials. As I mentioned, the patients have many comorbidities from PTSD, borderline personality disorder, and more, which may have more real-world generalizability, but at the same time, these comorbidities may play an important role in the findings that we observed. And lastly, these are simple questionnaires, the PHQ-9, very simple questionnaire with no patient-centered outcomes. And we didn't test psychotherapy or other contextual factors that may play a role in these treatment outcomes. So future steps would be first to try to replicate these with pre-registered analyses in an untouched data set. That would be the only way to know if these exploratory findings do in fact generalize. It would be also quite interesting to explore how the results may differ for other indications like PTSD, for which ketamine has been suggested to potentially be helpful, and also interesting to explore other modalities like psilocybin-assisted therapy, TMS, and others. It'd also be interesting to see if there's other predictors we could use beyond simple questionnaires like brain imaging, physiological markers, maybe even long-form text in the era of large language models. And lastly, how might these findings inform mechanistic inquiries into the nature of these treatments? I'd like to thank the co-authors of this work, Dr. Ramanathan, the PI of this work, as well as all the other members of the UCSD NEAT lab, from whom these data and these analyses were greatly contributed, as well as Roger McIntyre, who helped with some of our analyses and interpretations of data as well. And I'd be happy to answer any questions or any clarifications at this point.
Great. Well, thank you very much indeed. That's really, really clear. Thank you so much. So please do put your questions in the chat, or if you'd like to put your camera on and just indicate or put your hand up or indicate that you want to ask a question, that all of that's good. I'd like to just ask if you can sort of set this in the context of the way that you approach this compared to how other people conventionally look for predictor symptoms. Was yours a standard way of doing this, or is it? I mean, I understood what you were doing, but is that the standard way that people explore predictor symptoms?
Well, I feel like what we did is a fairly basic and a first pass way that would be useful for anyone looking at predictors. I know that there was a prior result also in psychiatry research not too long ago that found anhedonia, baseline anhedonia, to be a positive predictive response, and also interestingly, may have also found some negative results with SI in that as well. I don't know to what extent these methods have been used in terms of many papers, but I do know that they have been used before and are certainly a very simple kind of way of not doing anything fancy, just looking at symptoms and doing logistic regressions. In terms of the threshold tuning approach, I'm not aware of any results in ketamine that have used that before, to my knowledge.
And in other spheres of medicine, but is that threshold tuning a sort of a standard approach?
Threshold tuning, it's a standard thing in machine learning to look at that. I'm not too fully aware of to what extent it's used in medicine. I'm sure it is because it's a common approach in machine learning more broadly. But I unfortunately can't speak to how widely it's used in medicine in particular.
Okay, maybe some of our audience can add value to that. Okay, so thank you very much. So in the chat, our first question was, PTSD wasn't measured against TRD, but what was your clinical impression? And the second question, you measured self-harm. Was there any measure of suicidal thoughts or impressions? That's about what the PHQ-9, that item covers.
Right. Regarding clinical impression, though I can't speak to basic clinical intuition because I was only doing a secondary analysis of the data. I was not a clinician on these studies. I can say that, as I mentioned in the paper, I was not able to see in the data significant differences in the first principal component, the measure of response, based on whether patients did or did not have a diagnosis of PTSD in addition to depression. But unfortunately, because I was not a clinician in this data collection, I can't speak to clinical impression. With regard to self-harm, that really comes from the PHQ-9 itself. This is really just specifically measuring item 9 of the PHQ-9, which talks about thoughts of both self-harm or suicidal ideation.
So it's about thoughts rather than behavior.
Correct.
Yeah.
And I do not have in this data set, at least not that I've analyzed, any data about past attempts.
Hello, was Ibrahim, did you want to say something? No. Okay. So next question is for baseline symptoms, how do you make sure the patients are medication free?
Patients were not, because this was a real world study, patients were not guaranteed to be medication free. So that is another potential limitation of these analyses that, and I didn't actually in this particular project break out patients based on specific medications that they were or were not on at the time of this study.
Okay. I'm not sure I understand this question, but is there any machine learning like random predictability?
One thing that is important in machine learning is the generalizability of analyses, because there's a possibility of overfitting to the data. And we did use a repeated k-fold cross-validation approach to try to reduce the likelihood of overfitting to the data. I will say that in hindsight, even more robust approach would have been something called nested k-fold cross-validation, which can, once we've identified the best model, even more robust method that we didn't include in this paper would have been something called nested cross-validation. I did, in hindsight, have done that and showed that using a nested approach, it may slightly reduce the predictions from maybe 91% to 85% or so negative predictive value. So there's a chance there could be some overfitting in the methods we use, but we did use the cross-validation methodologies to reduce that. That being said, no matter what you do with cross-validation, fundamentally, this is an exploratory data set, a single exploratory data set that we've sliced and diced, analyzed in many different ways, pre-processed the data. So fundamentally, it is only an exploratory result and will require replication in an untouched data set to know how well it would generalize.
Sure. So Tiago Gil says, we know in previous work that ketamine is more effective than esketamine. Why would you include esketamine and ketamine together?
Yeah, I think that was a decision that we decided to go for just in part because we did analyze and see that there was no difference, at least on our response measure, based on whether patients received ketamine or esketamine. And that gave us some justification for collapsing the data together for the analysis. But it's a really good point that there may have been other factors other than the first principle component that we're unable to or did not analyze that might differentiate the two. So certainly that is a heterogeneity in the population we're looking at.
Yeah, it wasn't a huge sample either, was it? But it was what it
No.
was. Were there any dropouts, and how are they compensated for in the analysis?
I'm only analyzing patients for whom we have who actually completed a ketamine induction course of at least, as I mentioned, at least 2 to 7. Actually, the majority of the patients completed all 8 induction sessions. So did not analyze data from patients who dropped out after an initial ketamine treatment.
Okay. So anybody else have any questions that they want to, if they want to ask, they should please just let us know. Can you just say a little bit about the context of the clinic itself? Just everybody,
Yeah,
a lot of
I don't know
clinicians here are sort of interested in. I realised that you weren't a clinician, and Dr. Ramanathan, I don't think is here. But are you able to say, where it was being held and what sort of context it was?
Yeah, I don't think Dr. Ramanathan's here that I see. Again, unfortunately, I wasn't a clinician in the clinic. I can say that it is a clinic that's operated through the San Diego, California VA Medical Center. Dr. Ramanathan and one or more other attending psychiatrists operate this clinic, and veterans, United States military veterans with indications such as treatment-resistant depression can be referred to that clinic. It's actually just sitting within the VA Medical Center itself. I can say that it was not a psychedelic assisted psychotherapy type clinic. It was more of a, patients coming in receiving treatments with psychological support, but not psychotherapy or extensive integration sessions. But beyond that, unfortunately, I can't really speak to the details of the clinical day-to-day in that clinic.
Okay. And just from your sort of making the data sing, if I can put it like that, did you think that, I mean, I was sort of impressed with the logic of the argument that it was good to try and predict who might not respond because, as you say, because that's the clinical actionability of that, and that's not an argument that I've often heard before, but I think it's a good one. And it's just say for the sake of argument that your results held up, and that this idea that a relative emphasis on suicidality compared to mood would be somebody who you would be something that would make you think that somebody was less likely to respond. You sort of referred to it, but just to explore it a bit, do you think that suggests a degree of borderline emphasis in the presentation might be people who are less likely to respond?
Yeah, I think that's a really good point, and just trying to hypothesize, brainstorm a little bit about why these findings may have arisen. That's the first one that jumped to my mind as well, is that could there have been other comorbidities such as borderline personality disorder that may be speaking with a more higher weighting toward SI or self-reporting of SI. And we know that some personality disorders may be less likely to respond to treatments for depression. So that could be playing a role, or other comorbidities. I think that's one hypothesis. Another one may be that, as we continue to explore the notion that major depressive disorder is probably not one underlying brain physiology or one underlying condition, but perhaps a collection of symptoms that may arise from multiple different underlying symptoms. I think a future goal of this sort of work would be to try to better disentangle subtypes of depression, which maybe a certain pattern reflective of such a different subtype of depression, which may change the treatments that are more effective for that.
Yeah, and are you aware of data sets that are being examined using the same sort of methodology?
I'm not aware of other. I know that first of all, I know that the notion of trying to understand things at a symptom level, going all the way back to the interest in psychiatry to view these things beyond just simple ICD or PHQ-9 or ICD or DSM diagnostic clusters, is of great interest. I'm not aware of the full range of different sorts of approaches, especially threshold tuning type approaches that have been used to try to disentangle this. But I think that the broader topic of trying to understand things at a more symptom level, or even at a behavioral measure, are there certain behavioral tests that may be able to disentangle certain cognitive phenotypes or certain behavioral phenotypes that can help us view these conditions in a more nuanced way rather than just a diagnostic label is of great interest, but for many people.
Yeah, we have such a poor record on biomarkers that it's obviously the first thing to try out, isn't it? Mm.
Yeah, yeah. And also I'm interested in this finding that patients that were responders had higher scores on all the symptoms. This notion that patients coming in with worse baseline depression were more likely to respond was a little bit counterintuitive to me, thinking that maybe worse depression would be more treatment resistant in some way. And I know that there have been some data suggesting that previously. At the same time, we talk about in our discussion in the paper the common finding that in clinical trials, medication will often separate from placebo more strongly among the more severe depression patients, whether that's because the more severe depression is responding to the medication more, or the placebo is less effective for more severe depression is unclear, but that's one set of data that sort of is in the same line as what we were finding, but was a little bit unexpected, I will say, for me at least.
Mm. Makes you wonder if there's something about this particular population of veterans, doesn't it? And whether there's something about how symptoms are reported.
Right. Yeah, could it be a more about the reporting of symptoms rather than some objective measure of if there was any way of getting at that?
Yeah. I suppose one would have to look and see whether there were differences in clinician-rated symptoms, whether the scores, whether the finding panned out the same in clinician rating than
Yeah,
self.
absolutely.
That would be
Absolutely. Yeah, it'd be going back to the idea that these are very low dimensional and simple measures that we're using with the PHQ-9.
yeah. Well, I think as a medical student project, this was pretty good, and you've obviously extracted a lot from it. I hope we've learned a lot from it. I hope you did too. And it's great to have to see that the data that have been collected are being used as part of medical student projects. So thanks for that, and I hope maybe there'll be other medical students who will present their project data as well from real world analysis. I think it's a good precedent. So thanks very much indeed for that. I think I haven't
Thank you.
detected lots of other people champing at the bit to ask questions. So I think we're going to wrap up at that point. However, before everybody goes, I'm just going to let you know what the next, if I can find it, what the next talk will be. And this will be about inflammation and ketamine, and that's going to be in 2 weeks' time. So I hope you're able to join us on the 11th of June for complement system and ketamine's mechanism of action at the same time. And that's Prof. Pillai is going to be talking to us at that point. So thank you very much. Thank you very much, Eric. Thank you to the audience, and look forward to seeing you then.
Thank you.
I'm just going to turn the recording off now.